Hello everyone, welcome to a very interesting session in blood vessel pathology. Today we are going to discuss vasculitis. What do you mean by vasculitis? Inflammation of the blood vessel. See, this is one of the most, difficult and at the same time one of the easier topic you will encounter in CVS pathology, because if you know the salient points or the keywords or the hints, it will be easy to solve any type of complicated case scenario based questions that they are going to ask in your prof exams. Fine? Yes. So I'm going to talk concise, very precise, okay, so that whatever case scenarios they have given, it will be very easy to pick up and you can make the correct diagnosis and you can write the rest. Fine? Yes. See, we have vasculitis means inflammation. So whenever we heard the word inflammation, we always think about infectious etiologies. But remember, in vasculitis, we have infectious as well as non-infectious vasculitis. Just remember, whenever there is a direct invasion of the vascular walls by the infectious pathogens, we call it as infectious vasculitis. But the most predominant type of vasculitis, what we are going to discuss today, is the non-infectious vasculitis. Fine? Yes. Remember, in our body, we have large, medium and small blood vessels. So, these vasculitis produce some distinct morphological and clinical features in all of these vessels. Fine. So, in each of these conditions, has some distinct features which clearly differentiate it from the rest of the other condition. So, today my discussion will be focusing only on those salient features. Fine. Yes. And remember, you will get multiple questions in your postgraduate entrance exam from this topic, vasculitis. It is one of the most important topic of interest for the Central Institute examiners. Fine. So first let us see about the non-infectious vasculitis. But before that, let us classify this vasculitis. I told you we have large vessel vasculitis, medium vessel vasculitis, small vessel vasculitis. In large vessel vasculitis are usually granulomatous disease. Granulomatous disease. See, each of my word is important. Fine. So please try to comprehend these things, these words, okay, and fix it in your cortex. Because if you are thorough with these basics, this classification, the basic mechanism, it will be extremely easy for you to write the pathogenesis, the morphology, and rest of the clinical features. So large vessels have granulomatous disease. So granulomatous means granuloma formation. So what will be the basic pathogenesis behind it? Yes, it is almost like a cell-mediated type of type 4 hypersensitivity reaction. So when they ask you about what is the pathogenesis of this giant cell arteritis and Takayasu arteritis, which are the large vessel vasculitis, you can write about type 4 hypersensitivity reaction. Simple, finished, pathogenesis finished. See, yes, so the first step has been over. In medium vessel vasculitis, we have immune complex mediated and anti-endothelial. See, immune complex. So what is the hypersensitivity reaction? Type 3 hypersensitivity reaction. The example is polyarteritis nodosa. Already we have studied in the Robbins, in type 3 hypersensitivity reaction, a beautiful table has been given. In that, polyarteritis nodosa has been mentioned. Am I right? It's an immune complex mediated. So when they ask about the pathogenesis of PAN, you will write type 3 hypersensitivity reaction. Anti-endothelial cell antibody, example Kawasaki disease. Okay, this you will write about anti-endothelial antibody. It is almost like an type 2 hypersensitivity. Finish. See, we have studied pathogenesis of how many diseases? 4 diseases: giant cell, Takayasu, PAN and Kawasaki. Finished. So that is the importance of basics. Fine. If you are well versed in general pathology, systemic pathology is extremely easy. Okay, no doubt. Okay, you can solve whatever complicated case scenarios, but you should be full thorough in your general pathology, the basic concepts. Coming to small vessel vasculitis, we have paucity of immune complexes and immune complexes. What do you mean by paucity of immune complexes? Means actually the proper immune complexes are not formed. It is like a paucity immune response. In other condition or other category, we have immune complex. It is almost like our PAN, where we have proper immune complex deposition. We have SLE, it is again a type 3 hypersensitivity reaction. Hinox-Schwann purpura, again it is type 3. Then good pasture is again, it is type 2 hypersensitivity reaction. Yes. So, and another thing is paucity of immune complexes. That means it is usually associated with some special categories of antibody called ANCA, that is anti-neutrophil cytoplasmic antibody. Don't worry. So we have microscopic polyangiitis, granulomatosis with polyangiitis and Churg-Strauss syndrome. These are the various. So you should know, please. Okay, this what to say. This chart is a VVIP diagram. You should be well versed with what are the various diseases. Okay, that is going to affect the large vessel, medium vessel and small vessel. You should be well versed with this. Okay, and I have already explained what is the basic pathogenesis. So when they ask you, yes, what is the pathogenesis of Kawasaki disease, you are going to write type 2 hypersensitivity reaction. Finish. That's it. I'm not going to discuss unless and until there is a a specific pathogenetic mechanism involved. I am not going to explain this again and again. Fine. Okay. Now let us see what are the various mechanisms. I told you, immune complex mediated. What is that? Immune complex associated vasculitis. Okay, already I have studied that. You know what is the mechanism. It is a type 3 hypersensitivity reaction. Okay, I am not going to explain it here. Yes. Then this immune complex. Okay, fine. Next is what we call as anti-neutrophil cytoplasmic antibodies. That is called as ANCA. What do you mean by ANCA? They are nothing else but some group of autoantibodies against the constituents of neutrophil primary granules. You know, we have in neutrophil, we have primary granules and secondary granules. So anti-neutrophil cytoplasmic antibodies are the set of autoantibodies which are produced against the primary granules of the neutrophil. Just remember this. And in this ANCA, we have two classification. Okay, two categories of ANCA are there. Okay, earlier we used to classify them as cytoplasmic ANCA or C ANCA and perinuclear ANCA or P ANCA. But remember, these terminologies is obsolete. We are no more using these terminologies. Fine. Yes. So we are using two important terminology, that is called anti-proteinase 3. Okay, that is previously called as C ANCA, and anti-myeloperoxidase, which is previously called as P ANCA. Very, very important. Okay, yes, this anti-proteinase 3 or C ANCA, which is earlier, I am not going to use C ANCA or P ANCA. I am going to use only anti-proteinase 3, and next one is anti-myeloperoxidase. So anti-proteinase 3 means the autoantibody which is produced against proteinase 3, which is a neutrophil acidophilic granule. Finished. This is found in a condition called as granulomatosis with polyangiitis. It is a, yes, you are going to tell whether it is a large vessel, medium vessel or small vessel. Small vessel. In small vessel, I have told you immune complex and a post-immune complex. So granulomatosis with polyangiitis, it was earlier called as vaginous granulomatosis. Again, that terminology is obsolete. We are not using that. So granulomatosis with polyangiitis is a post-immune complex mediated type of vasculitis of small vessel. Anti-myeloperoxidase. Here the antibodies are produced against myeloperoxidase. You already know what is the role of myeloperoxidase. Am I right? Yes. It is also associated with microscopic polyangiitis and Churg-Strauss syndrome. So anti-proteinase 3 is associated with granulomatosis with polyangiitis. Anti-myeloperoxidase is associated with microscopic polyangiitis. Granulomatosis with polyangiitis, microscopic polyangiitis. You know, both terminologies appears to be similar, but both are entirely different. No worry, we will discuss. And Churg-Strauss syndrome. Okay, Churg-Strauss syndrome is also called as eosinophilic granuloma. Fine, eosinophilic granuloma with vasculitis. Okay, we will discuss that. No worries. Fine. Okay. Then we have something called as anti-endothelial cell antibody. This is going to mainly affect Kawasaki disease, which is a medium vessel vasculitis. I told you Kawasaki disease anti-endothelial cell antibody. So what is the type of hypersensitivity reaction? Yes, very good. It is a type 2 hypersensitivity reaction. So let me revise once again what all points I have discussed, because it's very important. Okay, unless this is a table which is given in Robbins, but I won't ask you to remember this table as of now, because once you are thorough with each of this condition, just for revision purpose, okay, you can use this table, because or else you have to by heart each and every point. Let us come to each of this condition, each of the vasculitis, and at last we will come to this table. Fine. Okay. So first, please go through this. Okay, first you should go through this. Once that is done, you should know immune complex. Okay, then ANCA, anti-endothelial cell antibody. ANCA, P ANCA, C ANCA, the terms are obsolete. We are not using that. We have anti-proteinase 3 and anti-myeloperoxidase. These are the two set of antibodies you have to remember. Okay, yes. Once this is done, let us now, in this video, I am going to discuss large vessel vasculitis, that is Takayasu arthritis and giant cell arthritis. Fine. Please pay attention. Each point matters. Each point is very, very important. You can get any number of multiple choice question from this vasculitis. Actually, it is one of the most favorite, thrilling topic like a hot topic for the Central Institute examiners, because they will always ask, in from the questions from in between the lines. Okay. Oh. First cell is called as giant cell. Please pay attention. Listen to each and every word I am going to whisper out. Fine. Yes. Please listen. Giant cell or temporal arteritis. The word temporal won't be given usually, because I will tell the reason for that. First, remember giant cell. Have you heard across this word giant cell before? Yes, we have studied in granulomatous inflammation. We have giant cell which is multinucleated. Am I right? Multinucleated. We have studied Langerhans giant cell, which looks like a horseshoe shaped. Am I right? Horseshoe shaped Langerhans giant cell. Yes. Why? Because it is nothing else but a granulomatous inflammation of large arteries. First point. That is the first point. Second point, it principally affects the arteries of the head. Each point is important. In case scenario, they will ask, a patient comes with the tenderness or pain over the head. That will be the classical clinical case presentation. That will be the classical case scenario they are going to give in giant cell or temporal arteritis. Fine. Why it is called temporal arteritis? Because the temporal arteries are most commonly involved, and out of that, superficial temporal artery is the most commonly involved artery in temporal arteritis. Fine. In this picture, you can see the enlarged, dilated, superficial temporal artery. Yes. Once this is done, but remember, this temporal arteritis is actually like a more or like a misnomer, because it is not only the temporal. Of course, the temporal arteries are most commonly involved, but vertebral, ophthalmic, as well as even the aorta are also being involved. Fine. Yes. See, the patient will present with a sudden onset of blindness. Very, very important. Sudden onset of blindness due to involvement of ophthalmic artery. Very, very important, because ophthalmic artery can involve sudden and permanent blindness. So this will be one of the point that they will be giving. What is the pathogenesis? You already know it is a T cell mediated immune response. I am not going to talk much about. Already it is a type 4 cell mediated type 4 hypersensitivity reaction. Okay, granulomatous inflammation. You are going to write that pathogenesis. Fine. Yes. Now, let us see into the morphology. This is the point you have to focus. Okay, they will give a case scenario and they will ask you. Okay, see, the involved arterial segment develop intimal thickening. Okay, you can see a thrombus in the lumen, which is going to reduce the luminal diameter, and there will be classical granulomatous inflammation, which is seen in which layer? Media. See, in intima, you will see thickening, thrombus, occlusion of lumen. In media, what we'll be seeing? Granulomatous inflammation. This question has been asked in AIMS 4 years back. In which layer of the blood vessel there is granulomatous inflammation? Everyone write intima. No, it is in media. Fine. Yes. So there is CD4 plus T cells infiltrate. Biopsy is the investigation of choice. Very, very important question. What is the investigation of choice in temporal arteritis? The answer is biopsy. Fine? Yes. Clinical features, extremely important. More than 50-year, female, fever, fatigue, weight loss, headache, most intense along the course of superficial temporal artery, sudden loss of vision. Why? Because of involvement of ophthalmic artery. The patient may present with complete visual loss. What is the diagnosis? Even in the midnight, you have to answer it is giant cell or temporal arteritis. Okay? Yes. Okay. Then, coming into biopsy. I told you diagnosis depends upon biopsy. But remember, for biopsy, at least one segment of the artery. Okay, if you want to diagnose this through biopsy, at least 1 centimeter of the artery should be involved. Okay, this is very, very important. At least 1 centimeter, yes, at least 1 centimeter segment of the artery should be involved. Fine? Yes. Suppose in biopsy, okay, suppose in biopsy, you found that there is no granulomatous inflammation. Then also you should not say that this is not temporal arteritis. That means biopsy may not always give the correct diagnosis. Why? For in order to prove that in biopsy, at least 1 centimeter segment of the artery should be involved. So even though in biopsy we are not able to find, the clinical features has to be taken into consideration and we have to make the correct diagnosis. I hope you are clear with this. Yes. Next is what we call it as Takayasu arthritis. What is Takayasu arthritis? Yes, fine. This looks somewhat like a Japanese name. Yes, of course, it's a Japanese name. So Takayasu arthritis. Okay. What is Takayasu arthritis? It is a granulomatous vasculitis of medium and large arteries. Again, it is large arteries. Don't write medium, and of course consider it as a large artery. It is also characterized by ocular disturbance, but the characteristic point I have to mention is there will be weakening of pulses in the upper extremities, hence the name pulseless disease. Takayasu arthritis is called as pulseless disease. Why? Because it is going to mainly involve the aortic arch, subclavian vessels. Okay, so what will the typical case scenario they will be giving? There will be absence of pulsations in the left upper limb, whereas in the right upper limb all pulses are normal. Why? Because this arthritis is going to involve the subclavian artery. You know, from the subclavian artery we have the axial, brachial, ulnar, radial. So there will be absence of pulsation in the radial artery. I hope you get this point. Fine. Yes. Here also the patient age will be over 50 years. Fine. Yes. Okay, this is most commonly traditionally associated with the Japanese population. That is why, but it doesn't mean it is found only in Japan. It has a global distribution. Fine. Yes. So you can see the gross photograph. Okay, you can here see there will be what intimal thickening and adventitial fibrosis. Okay, adventitial fibrosis. Okay, intimal thickening. Adventitial fibrosis or intimal thickening. Okay, yes. Now let us see the morphology. So what are the features? Pulseless disease. I have already given the typical case scenario they will give. Fine. Yes. So what is the? I told you it classically involves the aortic arch. Okay, it classically involves the aortic arch, then pulmonary artery. Okay, even the coronary and renal arteries will be involved. There will be irregular thickening with intimal hyperplasia, lumen obliteration. Fine. And there will be adventitial infiltrates with the mononuclear inflammation. Okay. So you can see mononuclear infiltrates. Okay. Mononuclear infiltrates in the tunica, media and adventitia. Fine. Yes. Okay. Actually, the histology is very difficult to distinguish it from giant cell as well as giant cell arthritis. So that is why we have to always think about the clinical features. I told you, weaker pulses, reduced blood pressure, okay, visual disturbances, neurological deficit. All these are very, very important. Sometimes the patient may present with pulmonary artery hypertension or coronary artery disease because of the involvement of coronary arteries and the pulmonary artery. Even the patient may comes with renal artery stenosis also. Fine. So these are the important points that you have to remember. These are the very important points you have to remember. See, this is the aortic arch angiogram. You can see the luminal narrowing. Okay, you can see the luminal narrowing. You can see a small constriction there. Fine. Yes. So these are the very important points. So in this session we have discussed. I am again repeatedly each point. Don't try to mug up things because on long run it won't be useful. Fine, just understand what is the concept. Okay, just understand what are the features which distinguish each of this condition. You itself prepare a tabular column. Try to write down the points that differentiates between giant cell arteries and Takayasu arthritis. Okay, so because the self-made notes only will what help us at last. It's not any printed materials or anything. It is the notes that we are making which will help in long run. So please go through this, the basics, and in the next session we will be discussing the medium-sized and small vessel vasculitis. So thank you.